I had planned to come on camera, but my internet is being just a little unstable. And so just to give my computer a little bit more stability, I'm going to keep the camera off. So hopefully we don't have any blips. But thank you so much for the introduction. I am talking about the dreaded COVID-19 surveillance that we have here in New Hampshire. I too am sick of it. I will just go ahead and say I'm right there with you guys. It is an unfortunate condition that we were introduced to many years ago, and it has lingered, unfortunately. That being said, just a little bit of background on me. I started with the state as a COVID-19 epidemiologist May of 2020, worked my way up to actually being the COVID-19 program manager. And in January of this year, I applied for and received the very fun job of surveillance epidemiology program manager. So I moved over laterally, and now I get to see so many more fun conditions, but COVID did come with me over into my surveillance section as it kind of got absorbed. So now I oversee foodborne surveillance, waterborne, which includes wastewater, which we'll talk about here today. I also oversee respiratory, including influenza, and some of our COVID reportable pieces. So it's not fully reportable anymore, but we still monitor it situationally. I also oversee our vaccine preventable. We have a maternal health epidemiologist as well, so we have some conditions under that, as well as our vector-borne, which is tick and mosquito-borne illnesses. So much more disease conditions under my purview, which gives me some diversity in my day. But I'm happy to be checking those boxes and talking with you guys today about COVID-19 and wastewater surveillance in New Hampshire. So thank you so much for having me. And again, my name is Bailee Ahee. It is commonly mispronounced, but that's totally fine. So a little trick to remember is ahi, like ahi tuna. All right, moving on. So a little bit about our COVID-19 surveillance, what we have left at least. As of May 11th, 2023, New Hampshire Department of Health and Human Services basically discontinued and made it no longer explicitly reportable under our New Hampshire RSA 141C. And so that kind of came after the end of the public health emergency, but it lagged a little bit. I think we were about a year off or so from the public health emergency ending. Actually, no, sorry, right on time. We ended our reportable condition right alongside the public health reporting. We continued to receive voluntary reports for a year, and of May of this year, we have discouraged reporting because we lost our contractors and we're no longer able to process all of these reports that were still coming into us. That being said, we are still monitoring our severe conditions, so individuals who are severely hospitalized or death conditions that result as COVID-19. We're still monitoring those as they get reported. And then we are still receiving any outbreak information. So while we're not receiving electronic lab reports or provider reports of COVID-19, we're still accepting information from reporting institutions as they are obligatory to report any outbreaks within their facilities that include not only COVID-19, but really any illness or unusual occurrence, again, under that RSA. So we do continue to keep an eye on it through our wastewater surveillance as well, in addition to the death surveillance, as well as our multi-inflammatory syndrome in children. So that's one of those severe outcomes where COVID can develop more of like an inflammatory response within children. It is very rare. We haven't had a single report of it this year. We had only, I think, 30 or so cases of it throughout the last 5 years. So it is rare, but we do monitor for it through our surveillance just to kind of keep an eye on that situation. But what I'm going to kind of dive into a little bit more is our wastewater surveillance. And if that is a new concept to you, I wanted to kind of introduce it. So what is wastewater surveillance? It is a powerful tool to estimate the amount of pathogens, so like SARS-CoV-2, influenza, and respiratory syncytial virus, which is commonly known as RSV. It's a way of measuring it within the community. It's intended to supplement the data that is commonly reported to New Hampshire, as well as other health departments. And we use it alongside the severe outcomes and other non-reportable conditions. Sorry, my mouse clicked. To keep an eye on what's going on within the community alongside any outbreaks in congregate settings. It does allow for situational awareness within the community so that people have information to help make decisions for themselves and their health. Some benefits of our wastewater surveillance. So it can show changes in our disease trends before trends are actually seen in clinical cases. And this information is actually really helpful for healthcare providers to prepare for any upcoming increases in visits, hospitalizations, and it can inform other public health prevention efforts. It can detect people or infections in people in the community, whether people are having symptoms or not. And unlike other types of public health reporting, wastewater monitoring does not depend on people having access to healthcare, visiting a doctor when they're sick, or any availability of testing for infection. Wastewater monitoring can actually meet the changing public health needs, and it's really readily adaptable to meet any emerging health threats. So some states have onboarded additional targets like H5, which is avian influenza, and polio. There's a few other states that have other targets on board, but I won't go into listing them. It's kind of situational. And I will talk about which targets we monitor for here in New Hampshire. But all to be said, wastewater data is the most useful when it can be used with other surveillance data. So when reviewed all together, wastewater and other surveillance data can provide more complete picture of disease spread within a community. Going on to our limitations of this. So as valuable as wastewater surveillance is, it is not always possible to reliably and accurately predict the total number of infected individuals in a community, just based on wastewater surveillance alone, that is. Wastewater surveillance will not necessarily represent homes that are on septic tanks or septic-based systems, though some facilities do actually accept waste from these septic systems. This can have very low results, but it can have an impact nonetheless. Some low levels of infection in a community may not be captured by wastewater surveillance if the quantity of a pathogen falls below the limit of detection for laboratory surveillance and analysis. Community level wastewater surveillance at a wastewater treatment plant will not represent communities or facilities served by decentralized systems, so prisons, universities, or hospitals. That being said, some of our surveillance systems or wastewater facilities are in college towns. So while the university might not feed directly into that wastewater facility, the residents and students in that area obviously will contribute to that facility strongly. Wastewater is a complex sample, and variability in measured concentrations are expected to do, or can be expected due to environmental variability, rain or drought, day-to-day difference in wastewater flow rates, changes in population size, such as tourists and seasonal visitors, and then laboratory tests that are used. Trends can be more reliable, again, as we start to compare it with other surveillance measures, and it can also reflect the variability and should be interpreted with appropriate context and with caution. So when you review our dashboard, which I'll talk about, do keep some of that context in mind. 1 second while I take a sip of water. So from toilet flush to results, it only takes about 5 to 7 days for us to get results. That being said, as a result, our dashboard has a 1-week delay from when samples are collected to when it gets updated, but it does get updated on our dashboard the same day that we receive the results from our public health lab. Wastewater monitoring from a single treatment plant can provide information on community level disease trends for hundreds and thousands and even millions of people. People with certain infections, such as COVID-19, can shed pieces of virus or bacteria when they use the bathroom, shower, when they wash their hands, or when they do their laundry. And so these pieces of virus or bacteria travel from the toilet sink, the shower, the regular sink, all the way down the drain into the sewage system. So before wastewater is treated, wastewater operators have been taking samples that are participating in our surveillance, and they send them to our public health lab. Laboratory tests on the wastewater samples are used to detect any circulating infections in the community. And again, this information is available usually 5 to 7 days after the waste enters the sewer. And then we do see that 5 to 7 days lag of our our samples. So I guess we're looking really at almost a 2-week lag, which still is earlier detection than when we would see clinical symptoms starting to arise, which I'll talk about here shortly. So here in New Hampshire, we have 14 wastewater facilities, as you can see on our little dots here. Some of these dots are red, just it was a snapshot from our dashboard. So some of these were representing higher rates, yellow being the least, red being higher detections or volume. So currently we only have 3 targeting tests, but we are, as we have increased our capacity within the lab, we're going to be increasing our targets as well. I believe avian influenza is one. I believe we might have hepatitis C that we might be adding. So stay tuned on what we add, but currently we're looking for COVID-19, influenza A and B, as well as RSV. And so a little bit this contributes to our pan-respiratory. So all things respiratory is what pan-respiratory kind of stands for. We're looking for all these respiratory illnesses within our wastewater at this time. So this is just an overview of what our dashboard looks like. I won't talk about the trends until a little bit later on. But if you go to it, I assume many of you have seen our COVID-19 dashboard. It's right alongside that COVID data. Right now, we're only displaying death data as well as some demographic information for our fatality cases. But overview, we have the map, which gets updated again weekly. It shows the trend lines here. So you can see which facilities have spikes and where they're kind of comparing to one another. And then our little dots that show where the facilities relatively are, right? So it's not perfect, but it shows which ones are having higher detections and which ones are lower and so on. And we have it relatively interactive. So you can select certain facilities and then you can select certain conditions. Wanted to highlight some of the interactability. If you hover over the little dots along the trend lines, you can actually see more specific information for that specific sample. So you can see when the sample was collected. You can see where it was collected, what county that represents, the population served, and then the actual volume of viral detection that they had. Moving on to the next little piece I wanted to highlight before talking about our trends. If you hover over these little dots, you get a little bit more information. So very similar to what you'd see over these dots here, but now you actually get to see the viral variability from week to week. So we're looking anywhere for January 1st to now and what that seasonal trend has looked like. I don't know if I went backwards or forwards. I think I just have a duplicate here. Okay, we'll keep moving on to our trends. So I do want to talk a little bit about what we're seeing now. When I most recently gathered this data, we had only data up till October 1st. And that was when it had been updated last. So just kind of looking at our COVID trends, I want to talk about specifically these peaks. So as I mentioned, we specifically don't pull from universities and prisons, but sometimes the universities students population who are not residing within the halls, who live in the area, do contribute. And so that's actually what we're seeing here is from Durham and Newmarket, surrounding our back to school timeframe for those college students. So they returned, obviously, 5 days later. There's some shedding of COVID-19 particles into the wastewater, and that's what's going to lead into our big detection here. And I'm sure many of you have experienced that September time where everybody seemed to be sick. Inevitably, it was probably COVID. And so now we're seeing trends back on normal range. We'll continue to monitor and see what happens going into the winter season. But for the most part, it's been relatively stable throughout the year and through the summer. That being said, these are relatively high volumes. I think it's more just, it's here to stay, but these were really high detections. So you can kind of see actually the range difference. These are not necessarily to be comparable. Different viruses are going to have different viral copies, but I'll switch back so you can see that comparative difference. So for one, we're looking at peaks of 400,000, even in the low range, we're seeing 25,000, probably 30,000, up to 50,000 for some seasonal trends. But when we go to RSV, we're within that 10,000 and below range. So just to kind of see the difference in viral capacity. Again, they're not comparable. Doesn't mean that there's more people necessarily experiencing it. It's just the difference between the viruses, amount of virus that's needed to kind of cause infection. That being said, we did see some RSV trending high towards February and, later winter months. It's been relatively stable. We've started to see a little bit of a peak, so we'll keep an eye on that situation going forward. And then talking now about our influenza A specifically, very similar. We had some late winter, early spring detections, which makes sense as well with their school. So as school kind of let out, we started to see a stable trend. Historically, obviously, flu is not a summer illness. And that's actually going to be true for our RSV. It's really common in kids, so we see that trend while kids are in school. And as school returned, obviously, we're starting to see the upward tick into our fall and winter months. So again, we'll keep an eye on the situation. And looking at our influenza B, again, looking at our viral copies, it's much lower than COVID-19. So seasonally, it's just much less established, but also just different, as I mentioned. Not much else to note other than it did carry on through end of school season with a high detection there at the end of May. Something really cool about wastewater surveillance is that it does kind of lend you a heads up into what we could be looking at. So you can kind of start to see from our wastewater trends some peaks early on, some activity happening early on, that really helps to kind of coincide with our clinical data. That's all I really have for you guys today. I want to thank you all so much for listening in. You're welcome at any time to check out our New Hampshire COVID-19 and wastewater surveillance dashboards. We're hoping to develop a pan-respiratory dashboard to kind of replace that COVID-specific dashboard. I'm not sure if that'll get launched this year or next, but we are working towards it to kind of incorporate it into our respiratory surveillance as a whole, just to kind of give community members, again, a glimpse into what's going on within their area so that, again, they can make the best decisions for themselves. Thank you so much. Again, my name is Bailee Ahee. I'm happy to answer any questions if you have them.
Thank you, Bailee. That was great. Does anybody have any questions? I do.